Onc Live Insights is a video editorial program produced by Onc Live.
Multidisciplinary care for patients with prostate cancer is probably more important than ever. The vast majority of patients who I see as a medical oncologist, for example, have had some sort of urologic surgery. Many of them have had radiation, and for many of them, they continue to need urologic care, which is optimally delivered by a urologist. Alternatively, many urologists are continuing to learn about and be able to use some of the newer hormonal agents and indeed give standard hormonal therapy themselves. And so really there's a melding, if you will, or a coming together of the two disciplines in many ways around the area of advanced prostate cancer. There is progress being made in the search for predictive markers for prostate cancer. I would say that it's too early to say that we have a standard of care predictive marker that applies in all cases, but we're beginning to see certainly some very encouraging things. Certainly at the top of that list right now would be ARV7, which is an androgen receptor variant, and what this means is that patients who have this variant, what they have are essentially a preponderance of androgen receptors that are able to signal and be active without the presence of androgen. And the biology of this would mean that androgen synthesis inhibitors and androgen receptor antagonists would be of very little value for those patients. And in fact, that looks like that's the case. However, that biomarker that we know is very predictive is continuing to be developed and is not something that is able to be ordered from a standard clinician's office quite yet. This is a marker that requires the presence of circulating tumor cells, at least that's the current status of it, and it requires special processing and interpretation. Furthermore, we're not quite sure exactly the relationship between this biomarker of ARV7 and androgen receptor amplification and standard androgen receptor signaling or the presence of standard androgen receptors. So there's really a lot more that we need to know, but at least we see the beginnings of a predictive biomarker that would help us determine who are the patients who unfortunately are not going to benefit from one of the newer hormonal therapies. We continue to need and lack a predictive biomarker that will predict which patients will benefit from a particular therapy. But for many patients, having a marker that says this drug is not the drug for you, that is actually also very, very useful in terms of saving time, saving money, and avoiding disappointment. One common question is, what is the status of ARV7 over time in an individual patient? And it's really an interesting insight into the biology of the disease. The prevailing thinking right now is that ARV7 is likely to emerge as a predominant signaling force in the cancer as the cancer progresses. However, it is detected even in early localized disease. In fact, at this year's AUA conference just today, there was a presentation on findings of ARV7 in localized prostate cancer patients who are undergoing localized therapy. And so it is present there, but really the more important feature is what is the ratio of ARV7 to standard androgen receptor over time as the disease evolves. As the disease evolves under the treatment with androgen deprivation therapy or other types of treatments, it is likely that what happens is a selection pressure occurs. When the standard androgen receptor is blocked by drugs or androgen deprivation therapy, it can allow the outgrowth of the tumors that harbor the ARV7 variant. So it likely does change over time, but I would say that once it becomes present and becomes the predominant signaling force, it's unlikely to go away as a signaling force. So a patient who is, based on that test, unable to receive enzalutamide or abiraterone or similar drugs would probably not become more likely to receive it later. Although I think we'll be eager to see some new data on that regards, because one of the things that is being explored is whether or not chemotherapy, for example, might be able to diminish or eliminate even some of those subpopulations of tumor cells that harbor the V7 variant, making the tumor then susceptible to enzalutamide or abiraterone because of, if you will, normal androgen receptor driven cells remaining behind. The optimal time to test someone for an AR-V7 variant would be at the time when you're trying to decide about which treatment for castration-resistant prostate cancer to administer. So ideally, the test would be something that a clinician can order within a month, for example, of starting enzalutamide or abiraterone. And I think really if the test were to come back positive, indicating that there is a strong AR-V7 presence, that it would be best to avoid those therapies. At least that's how the data are looking now.